Thank you. This is the greatest public health challenge or crisis that we've had in our time, and that's keeping well in mind that only 8 years ago we faced a stage 6 global pandemic of influenza, and yet this is the greatest public health crisis that I've ever seen, and I think most of us have ever seen. Before I carry on, I'd like to acknowledge that we're gathered on the traditional lands of the Pacific Northwest Indigenous people, and I want to talk a little bit more about that population very briefly at the end of my topic, because I think there's a few learnings from the traditions of some First Nations in dealing with public health problems like this. But Indigenous people have also been a population who have been particularly hard hit by this public health crisis. And we're here in a province that has been particularly hard hit by this public health crisis. And so I'd like to thank, in addition for the invitation to CPSBC, for your participation in and leadership in solutions to this problem. You've also, by virtue of being so hard hit by this crisis, have some clinical experts and excellent pioneering researchers and public health leaders in BC who could probably speak to this topic better than I can, but maybe they said no to a Friday afternoon talk, I'm not sure. There's a lot that we could say about what we've called the opioid crisis, and we could spend an entire day or days talking about solutions to it, or the genesis of it, or the factors that have compounded the public health problem that we face. But I've got a bit of time, and I thought where I would spend it is talking about the space in between the ivory towers and the exam rooms, where much of the focus has been on this problem. There are ivory towers where academic questions are asked, and some of them are peculiar questions or obscure questions. There are crafted, canned key messages that come from these towers, and there are big decisions that are made in these towers. And then there's our examination rooms, where we put people in diagnostic buckets and where we treat them based on assessments that take place through our clinical lens. But in between those two places, there's a large, unavoidable, messy space where real life happens, and where a piece of toast and strawberry jam is as much a medicine as the things that we prescribe, and a place where we require 2 words for effectiveness and efficacy. And that space is poorly understood, I think, by us, and might explain why we've not done a good job at dealing with this public health crisis. So I should put up the obligatory slide where I try to convince the audience, and we try to convince ourselves, that the skin we have in the game doesn't compromise our objectivity. So I don't have any financial relationship with any industry, and that includes pharmacy, retail pharmacy industry, which I think is important to say when you practice addiction medicine and prescribe daily dispensed medications. But it would be foolish for me or for any of you to think that that means that I'm completely without conflict of interest, or that any of you are without conflict of interest. Conflict of interest is in everything that we do, and has really played itself out in this opioid crisis. I wrote about this in Stat in the spring, and I invite you to take a look at kind of broadening the discussion of what conflict of interest in medicine actually is. From my point of view, if you're somebody who practices fee-for-service medicine, you are in a conflict between your need to make an income and the need to deal with complex health problems. If you're a salaried physician, you're in a conflict between our convenience and comfort and the need to meet the population demand for our care and volume. If you are a researcher, you live in the context of publish or perish, and so the research questions that you ask and the way that you study those questions are in that context, and that introduces a conflict. And especially if you're in a bureaucracy, or you work for and in government, you have to live in that conflict where your paycheck depends on navigating mandate and marching orders in just the right way. And I think that we've seen in public health authorities the conflict of interest not favoring the public and population interest. So when I was in government, when I started out in 2006 with Health Canada, myself and a colleague, Dr. Seminani, started to look at using business intelligence approaches to analyzing physician prescribing behavior in First Nation populations or to First Nation people, because leadership in First Nations was very concerned about what appeared to be a growing problem of prescription drug adverse effects, including addiction, but other things as well. And so what we did was we looked at prescribers to people who were treaty status First Nations and had medical benefits paid for by the Non-Insured Health Benefits Program of Health Canada. And we saw stuff like this. So this is what we call the perspective map, where every rectangle that you see in that picture represents a single prescriber. And the color, the dimensions of that rectangle reflect how many unique patients that physician saw in a calendar year. And we're looking at the year 2008, to a particular First Nation community. And the color of the rectangle reflects what proportion of those unique patients were prescribed an opioid in that calendar year. The brighter the red, the closer to 100%. And so here you're looking at a prescriber who saw 369 First Nation patients in a year to whom a medication was prescribed, 91% of whom received an opioid prescription at least once. Now, this is in a primary care practice where there was no specialization in chronic pain management. The College of Physicians and Surgeons of Alberta took on similar technologies years later and were able to do analytics like this, where here we're looking at triplicate prescription program data, right? So those drugs that require triplicate prescription in Alberta. And looking at per ingredient, what was the amount of total oral morphine equivalents prescribed on triplicate prescription forms to the entire Alberta population. And the line that's probably of most interest is the, what do you call that, magenta? The top purplish line up there that grew a little more than 50% between 2006 and 2011, and you can guess which molecule that was. It was oxycodone. If you looked at total oral morphine equivalents prescribed in the triplicate prescription program to the Alberta population, again, a rise similar to what we saw in other jurisdictions between 2006 and 2011. 2012 is a bit of an off year because the triplicate prescription program data was then replaced by our pharmaceutical information network data, which is our kind of electronic medical record where all prescribing data was starting to come in 2012. And so it's probably under-reflective of what the total oral morphine equivalents were in 2012. But the take-home is there was a rise. And there was a rise in pretty much every North American jurisdiction. There was also a rise in Alberta, where I'm from, in acute drug toxicity deaths with or without alcohol where an opioid was involved, from 213 in 2011 to 291 in 2013, which by proportion is a significant increase in deaths. That reflected similar situations in the United States, where we saw from 2001 to 2014 a significant increase in the number of deaths that involved a prescription opioid pain reliever. Okay, so this is data that can't really be refuted, that the number of deaths was tracking with the total amount of oral morphine equivalents dispensed to a population. We might have made a bunch of conclusions about that may have held in 2011, 12, 13, and 14. May be different now. But it would be hard to argue that physicians, pharmaceutical industry, pharmacies, did not play significant roles in the genesis of this problem. 2012 to 2016, we were seeing, well, an increase between 12, 13, and 14 in total oral morphine equivalents. But then the slope sort of flattened out. And in 2016, our college registrar in Alberta at the time, Trevor Thiemann, was quite pleased, and he was right to be quite pleased, that some of the focused attention that they had paid to physician prescribing educating physicians about how they're prescribing compared to their colleagues in similar populations might have caused physicians to give pause to how they were prescribing opioids. And we saw a decrease in opioid prescribing in 2016. And we'll see what things look like in 2017. So that might have had to do with some of the things that CPSA was doing. There were other movements afoot by medical regulators in Canada and the United States where there was, as you know, the introduction of the CDC guideline on opioid prescribing and anticipation of the Canadian guideline, which I think is actually pretty good. In terms of what data is available on chronic opioid prescribing, and in terms of the process by which they arrived at these guidelines and tried to tease out conflicts of interest as best they could, with a notable mistake. If you read the Globe and Mail, you know there was an administrative error, unfortunately, that left as a voting member somebody who had taken money from pharma. But CIHR did not feel that actually changed the value of those guidelines, and that the guideline reflected the best evidence available. But the focus in this guideline, or some of the focuses in this guideline, had to do with max doses. Okay, because we like that as a guideline. We like to know, well, how high can we go? And the recommendation for patients with chronic non-cancer pain who are on long-term opioid therapy is to do our best not to exceed 90 oral morphine equivalents. And then for patients early in the treatment of chronic pain, that we do our best not to increase beyond 50 milligrams oral morphine equivalent. If you think of what formulations oxycodone, for example, is available in it, you know, people think Oxy 80, and Oxy 80 is about 120 oral morphine equivalents. We're already past it with one pill. There has been a bit of a preoccupation, with good reason, as far as what the max doses would be. And the recommendations also take a look at patients who are on those high doses, what we ought to do with them, and a weak recommendation that we try and taper those opioid doses to the lowest effective dose in order to mitigate the risk of adverse effects. And the adverse effects that we were most looking at are the ones that the literature gives us the best indication exist, but they're by no means the limit of what adverse effects can happen with opioids. Okay, so it's not just addiction and death, but also things like endocrine dysregulations, fractures, sweats, sedation, decreases in function, those sorts of things, constipation. You don't meet a lot of people on chronic opioids who don't have some GI problem. But in terms of addiction, a serious adverse effect of chronic opioid therapy, and the best data that they could find estimates that about 1 in 20 people on chronic opioid therapy will suffer from a substance use disorder. And as far as fatal overdose, that increases with the amount of opioid that the patient gets, to the point where if you're above 100 milligram oral morphine equivalents, your annual risk of dying from overdose involving opioids is about 1 in 400 people, which is really a significant risk if you think of the number of people who are on these medications. So for good reason, the guideline considered max doses and is giving us some advice on how do we do our best to mitigate the risk of those two things, but also others. But there's a saying in public health surveillance that what's important gets measured and what's measured gets acted upon. And we really did have access to prescribing data because prescribing is a transaction, or dispensing of a medication is a transaction that involves money, and of course we measure that. We measure how many transactions, we measure what was sold, we measure we count to whom it was sold and how often. But I would highly recommend that you read a book by Daniel Kahneman called Thinking Fast and Thinking Slow, where he describes a phrase that he coined early in his career as a data scientist. What you see is all there is. Or the acronym is WYSIATI. What you see is all there is. So if you're measuring something, you think that that's what's important. And because you think that that's what's important, that's what you act upon. And what we've seen in the drug poisoning epidemic, might be a result of us focusing some of our efforts in the wrong places. Now, I'm not by any means saying that we ought not to be addressing prescribing. That's right. But we ought to be doing that in lockstep with a whole bunch of other things to mitigate the risks of addressing prescribing in isolation. Some of you might have seen this before, but this is to illustrate the point that I'm trying to make. So how many passes does the team in white make with that basketball? Keep a close eye on them. Everybody get 13? Did you see the moonwalking bear? So the point is that if you're not looking for something ridiculous or something serious like a moonwalking bear, you're going to miss it. Because there's a lot of juggling going on with things like prescribing. You start to drill down into, well, what geographic areas is this prescribing happening? What specialties of medicine is prescribing the most opioids? What other drugs are they prescribing with these opioids? And what are the age demographics of the people who are getting them? But who stopped to think what happens to these people in that real-life space between the ivory towers where we measure stuff and the examination rooms where we prescribe stuff? And when we finally, when the Public Health Agency of Canada finally got their head out of their sigmoid colon and started measuring this stuff, which we still don't do a particularly good job of, believe it or not, of measuring death from this problem, we saw that in last year alone, 2,816 people dying from apparent opioid-related poisoning. That's one person every 3 hours in this country, which is really significant. And that's a serious underestimate. It's an underestimate because if you take a look at anybody, an epidemiologist in this room, that's good. When an epidemiologist takes a look at this table from the Public Health Agency of Canada, there's one in Alberta who took a look at it, and she had an acute panic attack and started to compulsively wash her hands, because if you take a look at the number of provisos in this very short table with one indicator in it, it shows you how poor of a handle we have on monitoring this problem. So take a look at all the caveats here. While in Quebec, they only report on closed and certified cases, and for 2016, only 44% of cases that involve drug toxicity are closed or certified. Sorry, of all cases are closed or certified. In Ontario, there's probably some similar delay as well. They couldn't provide January to March. There's always a delay in closure or certification of deaths, and so there might be an underestimate from Ontario. Saskatchewan only reports on closed and certified deaths as well. Alberta only reports on apparent opioid-related deaths, not on other drug poisoning deaths, which is different from BC, which reports on all drug poisoning deaths, except for if they're not illicit drug poisoning deaths. Okay, so BC is underestimating by those people who died with an opioid that you can find in your pharmanet was prescribed to that individual, if other drugs that are involved in that count were also prescribed to that individual. But they do make this list if you find something like bootleg fentanyl or cocaine or methamphetamine, or a drug that is a prescription drug that was not found to be prescribed to them. I actually think that BC's case definition is not horrible. I wish that they would also include prescription opioids, because we know that not everybody who dies from a prescription opioid has a substance use disorder. Not everybody who is only on prescription opioids doesn't have a substance use disorder. So those exceptions are really important, and I think substantial enough to materially change the number. But let's take a look at BC's, and like I said, their inclusion criteria. So to make, if your death gets included in this number, we would have had to have found a street drug, like those ones listed there, or a medication that wasn't prescribed to that individual. Taking a look at that number, oh, sorry, I don't know how that got there, or that, or maybe I'm trying to make a point. In Europe, the way they measure drug toxicity deaths is per million population. The way we've had to start measuring it and reporting it in Canada is per 100,000 population. And to give you an example, the reporting country in the European drug monitoring or drug death monitoring service, the leading country is Estonia. And I think that they're at 130 deaths per million. We're at 200 deaths per million in British Columbia. Again, an estimate that does not include prescription drugs. So where's the difference coming from? I think it won't be any surprise to you that if we were to remove those deaths that involved bootleg fentanyl, the curve for drug toxicity deaths is pretty much flat throughout 2007 to 2016, maybe a slight increase. Maybe that increase could be related to the illicit use of licit opioids, I'm not sure. But if you look at the gap, that delta of the difference between all illicit drug deaths not involving fentanyl and those that do, that's where we ought to be focusing a whole bunch of attention. If you look to 2017, I have to zoom out to show you what happens in 2017. But assuming that there is no change in the average, the mean number of illicit drug deaths per month, then extrapolating what happened between January and July of 2017, we should see, conservatively, the curve do that between 2016 and 2017. This is really bad, is the point. So those are the numbers that we see in our ivory towers, but if we were to look at what that means in real life, does anybody know what's happening in Oppenheimer Park today? So the crosses, yeah, they're putting stakes in the ground per person who has died from an overdose death this year. It will be row upon row upon row of people dying from drug toxicity death. It really is the greatest public health crisis of our time. Who are those people? I'll show you. This is what their faces look like. And you'll notice something about them. They're young. They're mostly white. And they look like anybody you might come across in a restaurant or a cafe. These are their moms. So on the left, that's Donna May, and she's holding a picture of her daughter Jack, who died in the Greater Toronto area. Leslie McBain is from Victoria. I've not met her, but that's her son Jordan that she's holding a picture of. Next to her is a friend of mine, Petra Schultz, and she's holding a photograph of her son Danny, who died at 25. He was a Red Seal chef. And then next to her, that's Jennifer Woodside. She's holding a picture of her son Dylan. All of them, I believe, in their 20s. And if you think about what that means from a public health point of view, so the way that we've not been reporting drug toxicity deaths, but that might be the best way to look at it from a public health and population burden perspective, is in potential years of life lost. So what is the burden of causes of premature death in our population? So I crunched these numbers myself, looking at what BC had reported, and I did it in as conservative a way as I could. So if you look, so they reported drug toxicity deaths in 10-year age demographic increments. So I assumed that everybody who died in each one of those categories was at the top end of that age group. So if it was up to 19, I assumed that everybody in that age group died at 19, everybody in the 30 to 39 age group died at 39. So I would surely underestimate the potential years of life lost per death. And if you do that, you come up with an absolute rate of about 880 potential years of life lost per 100,000 population, okay? if I were to assume that everybody who died was at the midpoint, which might actually be a more accurate way of doing it, it's not as conservative, but you get 1,020 potential years of life lost per 100,000 population. The reference age I used was 70, because that's the age that CIHI uses in order to report or compare our preventable death burden to other countries in the international community. And when we do that for other causes of death, take ischemic heart disease. This is right from CIHI's website. So in 2010, the number of potential years of life lost per 100,000 population under 70 was 230.1. Looking at all cancers, including childhood cancers, in 2010, so 2017 would be better than 2010, but in 2010, 845.6 potential years of life lost per 100,000 population under 70. And in 2010, from all external causes, meaning homicide, suicide, drug poisoning, and every single cause of injury, death that you can think of, 825.8. But now in 2017 in British Columbia, drug toxicity deaths alone as an external cause of death is responsible for somewhere between 880 and 1,000 plus potential years of life lost per 100,000 population. So people are dying at ages where they would be productive, where they would start to parent, where they would start to pay taxes, where they would be tradespeople and be involved in building infrastructure. This is a serious, serious problem, not just because death is bad, but also because of what it means to people who are not directly affected by a drug overdose crisis. So all of those people who die from drug toxicity in some way are exposed to a market. And this is a real-life market that exists where drugs are traded. And what was happening in that market, particularly around the time that OxyContin was reformulated, and you saw in those pictures, notwithstanding that the data is a little bit difficult to interpret in 2012, but you saw that there was a bit of a dip in how much oxycodone was prescribed to the population in 2012, 2013. And that has a lot to do with the reformulation of OxyContin into OxyNeo. And what you started to see was market forces in action in the illicit drug market. So if you go on your phone, if you're flying today, I don't suggest you do this, but if you go on your phone and search, where can I buy fentanyl, you'll find a whole host of websites on the open web that'll tell you where you can buy fentanyl, how much it'll cost you to get it here. You can find various analogs of fentanyl. So here you're looking at acetylfentanyl, which thankfully is less toxic than the bare fentanyl, or the parent fentanyl. And you can see that the per milligram cost is $40 shipped, and to buy a kilogram, it's $7,000. So it's all transaction cost. These drugs are very, very cheap to make, and anybody with a working understanding of how to run a chemistry set can do this. And they are, mostly from China, shipping it here with guaranteed delivery. So if it's interdicted, the supplier will tell you, if you didn't get it delivered, just tell us, we'll send you another package. Early, we would see mostly fentanyl in formulations of pills that look like OxyContin. This is a hand-powered pill press. If you're a little bit more ambitious, you might purchase one of these before they were regulated. So this one costs about $80,000. There's a picture of one seized by the Calgary Police Service. And then you would find dyes to stamp your Oxy 80s. This costs about $1.50 American, so like 20 bucks Canadian. That you would stamp the pill with whatever you want, and they'll make it for you. But if you want to make it look like a generic OxyContin, or if you want to make it look like a brand OxyContin, you would purchase the appropriate dye. And then you've all seen this picture in the press. I think every single news outlet has run a picture or run a story with this as its headline picture. So just to give you an indication of what the drug trafficker is thinking, I think, when they're deciding to get involved in this business. So a kilogram of fentanyl costs about $12,500. 1 kilogram gives you 1 million milligrams, and each tablet So a euphoric dose of fentanyl for a 70-kilogram human being would probably be around 1 milligram, 1 to 2 milligrams. So 1 million milligrams, or a kilogram of fentanyl, should give you 1 million street tablets. About $20 a tab. Gives you $20 million for a $12,500 investment, which gives you a return on your investment of 160,000%. If you were to spend 100 grand to buy your pill press and your fillers and your dyes and your binders, you get an 18,000% return on interest or investment for your first batch of fentanyl that you make. There's a whole bunch of reasons why drug traffickers saw this as an opportunity, particularly when the supply of prescribed opioids looked to be under threat initially, when that OxyContin change happened. And we saw this play out in real life in Alberta, where in Fort McMurray, which is quite far from our closest port city, but traffickers were moving heroin from Vancouver up to Fort McMurray and selling it for about $25 a point, which is not that much more than you buy it for in downtown Vancouver. But very soon after that, we started to see fentanyl show up in Fort McMurray. We had no opiate agonist treatment available in that oil drilling town or oil sands town. You could see that the drug trafficking market was adapting to a change in supply. And they were also adapting to a change in the price of prescription opioids. And this was also happening in Ontario. There were First Nations community in northwestern Ontario where a tablet of OxyContin 80 milligrams was going for upwards of $400. And people who were using 10 and 20 pills a day were finding ways to make that money. And you can imagine what sorts of desperate things people with substance use disorder would do to get their hands on this drug that was the only thing that could keep them functioning. So I think a good way to think of this is to use the introductory economics concept of price elasticity of demand to understand how the market adapts to these changes and how the market will adapt to more changes that we make. So first is a population of people who will perpetually use opioids, okay? So the first consideration is how necessary is a product. And price elasticity of demand describes how does demand for something change when the price changes. So when the price per point of price increase, how much does demand decrease? Because usually that's what happens. But if the product is extremely necessary, that difference is smaller. If you define the good specifically, so if the good is oxycodone and the price of oxycodone goes up, if you define the good as oxycodone only, then the price elasticity of demand is more inelastic. But if you define it as all opioids, then the market will adapt to price with demand for specific things. To illustrate, for example, in Ontario, you saw that there was a shift towards hydromorphone when oxycodone became non-formulary or when the formulation changed. What percentage of income needs to be spent in order to procure a product is also a consideration in perpetuation of use when price goes up. But when you think of the diagnosis of substance use disorder, one of the characteristics is people do whatever it takes. If that requires involvement in crime, despite them not wanting to, they will do it, oftentimes. And so we did see that in 12, 13, 14 in Alberta, the police were reporting increases in acquisition crimes in large proportions, and they tracked it back to the demand for opioid drugs that were going up in price. Brand loyalty you could see at play because initially when fentanyl came on the market, it was almost exclusively as those green 80s or those green monsters or green beans that they were calling, which were knockoffs of OxyContin. Duration of price hold is really important. In economics, if, say, for example, the price of milk went up by $1, if the price of milk went up by $1 for a month, people would probably continue to buy milk. But if the price of milk went up by $1 for 6 and 7 months, people would start to adapt their behavior. So they might move over to soy milk or almond milk. That example works better in Alberta because we don't really know what that stuff is, but you can I don't know, maybe I should talk about quinoa next time. I'm in BC. Availability of substitute goods, right? So if you could do something else, then an increase in price won't require the demand, or won't relate to a maintenance of demand. In terms of initiation of use, so nobody who doesn't have a substance use disorder needs a particular opioid. But I think there's a fair argument to say that the human condition in adolescence needs intoxicants. It's been that way since the beginning of recorded time. People have always used mind-altering substances. And people will use the ones that are most available and the ones that are most common. And opioids became very common between 2001, 2006, 2007. Very, very common. And the brand loyalty or appeal of OxyContin was really, really high. Newspapers were talking about OxyContin. In the United States, they talked about it as hillbilly heroin, which is a really great way to advertise OxyContin. And we might have done some of the same stuff with fentanyl, the way that we talk about it in media. And the way that the teen brain responds to those messages is usually to say, this stuff must be really, really good. And they probably know somebody who's using it. And they for sure know somebody who's using it and not dying from it. We talk about the ones that do die, but for every person that dies, there are tens or hundreds who don't. And the way that teenagers respond to that information is to say, I'm probably more likely the invincible person than the person who's died from drug toxicity. But I think that where I would focus is the duration of price hold. And we had an opportunity when pills went up in price, we had an opportunity to swoop in there and fill demand with treatment. And we didn't. But the market adapted very quickly to fill that demand with something else. And what they had to consider were those considerations of supply that respond to price changes in a market. And those depend on the availability of raw materials. I showed you, fentanyl is really easy to get. So you can import or synthesize the product instead of finding ways to get more of it prescribed and diverted. That's costly, and the latter, the prescribed and diverted, is costly and risky. But relatively speaking, bring yourself a shoebox full of fentanyl, which may be 3 or 4 million doses of it, is not that difficult to do and not particularly risky. For every package that's intercepted, there are dozens or hundreds of packages that make it through. In terms of cost, really the cost that they're concerned with is the risk, that inherent cost of bringing a drug across the border. And if you think of trafficking heroin in crates and in trucks versus trafficking a golf ball full of car fentanyl or a glasses case full of fentanyl, where is the drug market going to go in a criminalized system? It's going to go towards the more small molecule, which unfortunately for us is the more toxic one. And those are the factors that we're seeing in real life that have translated into the biggest drug safety crisis we've ever seen. Time to respond. So how long does it take the market to respond to a change in supply and demand, or to bring in a new product? And again, we had a chance, and we soiled the bed on that. How I think that this theory of how the drug market adapts is probably has some credibility. Well, we continue to see it. You remember when we all thought that W18 was an opioid, and when the drug traffickers thought that W18 was an opioid, they brought W18 over, thinking that it could be brought in 1/100th the package size as fentanyl could be. We saw carfentanil, and we continue to see carfentanil. And we also see other formulations of fentanyl, like stickers. But these are ways that the drug trafficking community will try and get around our drug laws. We know this is true because in Alberta, in the first 6 weeks of this year, we saw carfentanil involved in 15 deaths in 6 weeks, where in all of 2016, we only saw 30 deaths. So in 6 weeks, we saw half the number of deaths involving carfentanil as we did in the entire previous year. This is a picture of a drug market that's morphing. So what we ought to have been doing is providing that treatment for people with substance use disorder, opioid use disorder, that had the best evidence of effectiveness and the best evidence of retaining in a healthcare environment so we could do other things for these patients. And the most current meta-analysis on this is from BMJ not too long ago, where they looked at cohort studies of patients who were on methadone and buprenorphine versus those who were not. And those in treatment saw an overdose mortality rate of better than 1/5 compared to those people who were not in agonist maintenance therapy on methadone. And for buprenorphine, it was about 1/3. That's overdose death. But if you look at all deaths, all-cause mortality, there remains a significant benefit to patients being retained on agonist maintenance therapy. About 1/3 the deaths in patients who are on methadone versus those who are not, and about half the deaths in patients on buprenorphine compared to those who are not. The buprenorphine one, I mean, too small of a sample size that the confidence intervals were overlapping, but that difference of 2 to 1 is pretty substantial. Thing to keep in mind about that systematic review is that all of those cohorts, the enrollment ended, even in the most recent studies, by 2010, and they were studied for 5 or 6 years out. 2010 was different than 2017. In 2010, there was no fentanyl, not the bootleg kind that we're seeing now. In 2017, the risk of not being on therapy is much higher than the risk of not being on therapy in 2010. So necessarily an underestimate of the benefits of being on agonist maintenance therapy in that systematic review compared to what it would be today. And the second proviso is that systematic review did not include any studies in incarcerated people. And people who are in jail or people who are recently released from jail are at substantial risk of overdose death or from mortality from other causes. So starting patients who are in jail on agonist maintenance therapy, if they have an opioid use disorder, is really, really high yield. So, all right. So deaths, of course, is the tip of the iceberg in any public health problem because most people don't die from most chronic diseases, not in a year. So in 2008, when CDC looked at the number of people dying from prescription opioids compared to the number of people who, from their surveillance, appeared to have opioid use disorder, so that's a DSM-4 characterization, people who have substance abuse disorder, substance dependency disorder, which is what we called them in DSM-4, was about 130 to 1. Okay, so if we're talking about, say, 3,000 people in 2016 who died from an opioid overdose in Canada, 130 times that of people who have an opioid use disorder in Canada. So that's a lot of people. Taking a look at Alberta, between 2013 and 2017, or the fiscal years 13-14 and the fiscal year 16-17, we saw about a 1,350 person increase in the number of people who were dispensed methadone per year. And for buprenorphine, which, by the way, was approved for sale in Canada in 2007, we saw that in Calgary, which is a big city, not by Vancouver standards, but a big city, in 2013, we only had 71 people on buprenorphine in Calgary. Now it's a bit better. So there's been an increase of, say, 2,100 people between 13-14 and 16-17 on buprenorphine. So that's assuming that everybody who was prescribed one of those two agonist maintenance drugs stayed on it, retained in treatment. These numbers actually just show people who received one dispensation of it, not necessarily at the beginning of the year till the end of the year, but once they got it. So they accessed opioid use disorder treatment at some point. So in total, so if you didn't believe me about conflict of interest inside bureaucracies and governments, this, by the way, is how the Alberta government reported their increase in buprenorphine maintenance. Their most significant increase was seen in the South Zone, a 2,900% increase in the number of people receiving buprenorphine. But in whole numbers, that was 14 people to 470 people. no epidemiologist would be okay with characterizing the increase as a 2,900% increase. There's a deliberate attempt to show that things are better when things are not better. So between 13 and 14, the increase in Albertans who were receiving a dose of opiate agonist treatment between 13-14 and 15-16 was 3,422 people. Okay, overestimate again, not all of those people were on maintenance. The number of Albertans dying from opioid poisoning in that same time period was 1,406. And that's an underestimate. Because that does not include, Alberta has still not been able to release numbers of people who died from non-fentanyl opioids between January 2014 and December of 2015. The years previous, it was about 200 people per year dying from prescription opioids. So add 400 people to that number. You get 1,806 people who died from opioid overdose. And only 3,422 people who gained access to opiate agonist therapy, when it's somewhere around 130 people with an opioid use disorder per death. So we should have seen 130 times that 1,400 to 1,800 people who get access to a treatment that benefits them in terms of mortality and all-cause mortality risk. But we only saw 3,422. So we're not doing a very good job is the take-home on that. But it does, you have to ask the question that is the fatality rate the same from people who are using prescription opioids dependently or in a disordered fashion as it is from people who are using illicit opioids in a disordered fashion? It would be nice to be able to answer that question, but we can't. Our survey on drug use behaviors in Canada, which is the CTAD survey, took a look at opioid pain relievers. They ask it in a questionnaire, do you use opioid pain relievers? Do you use them to get high? Or do you use them for some reason that you were not prescribed for? And it looks like between 2013 and 2015, there was actually a decrease in the percentage of patients or percentage of individuals who reported that, yes, they did misuse an opioid pain reliever. And if you look at the actual numbers, they're unable to report any of them because the power of the survey is not adequate to even report a number. So this is the most pressing public health problem of our time, and we don't even know how many people are using these drugs. In terms of illicit drug use, the increase in illicit drug use between 13 and 15 was associated with an increase in the use of hallucinogens and ecstasy, not heroin. If it was heroin, we wouldn't know because, again, the sample did not have adequate power to be able to detect a number that they even bothered to report. And you can see that here. Beside heroin, everything is a dash because they could not in good conscience report the number given the poor quality of the survey. But if we want to do good surveillance, let me show you what they're doing in Ottawa and what I'm sure they're doing at overdose prevention sites elsewhere. They're actually recording what happens to people who use substances in these overdose prevention sites every single day on Twitter. So one of the nurses at the Ottawa overdose prevention site reported that of 47 visits, there was one overdose. They managed it with naloxone. The next day, 28 visits. One guest needed monitoring, tested the drug, fentanyl positive. And over the first 28 days of their operation, these were their numbers. These are collected in real time. And they would be so valuable to us in trying to manage an overdose crisis. We could also look to other surveillance tools like StreetRx. I don't know if any of you have actually visited this site, but it's a way for people who use illicit substances illicitly or heroin to report how much they're paying. And cost is a really important indicator of what the demand for a substance is or where the supply is coming from, and we don't monitor that at all. So I've mostly been talking about Alberta and BC, but does anybody know who this guy is? So this is David Gerling. He's probably the most prolific writer on the opioid crisis in Canada. He's from the University of Toronto, and he says a lot of smart things, and because he's from Toronto, they matter. But I think the smartest thing that he's ever said was at FEMRAC last year, where he said, I like to quote Hakique. This is videotaped, right? I have to make sure I show it to David, who said, there's never been a more dangerous time to use drugs from the street. And what I'm talking about when I say that is risk. And I don't mean risk as some nebulous concept, but actually risk being a calculation of the probability and magnitude and frequency of adverse events that happen from exposure to something. So risk is that calculation where we look at factors related to exposure and susceptibility at a patient level and a population level that comes from a variety of hazards. This is the first thing we learn in public health, and I think a really valuable construct in the clinical realm as well. So there's a number of things that have changed. One is the hazard. The hazard is probably more toxic. And exposure has to do with the number of exposure events. How often are people using these substances? The characteristics of the exposures that happen in terms of the route, the dosage, and susceptibility factors, patient factors like comorbid conditions, drug-drug interactions, clinically drug grapefruit juice interactions. In terms of susceptibility on a population level, those people who are isolated, those people who don't have access to emergency care, those people who don't have phones to call for an ambulance, those people who are in places where pharmacies refuse to dispense naloxone. Those are susceptibility factors that play into our calculation of risk. We don't know in Canada what's happening with routes of exposure, but we do know from studies in the United States in San Francisco that the time between initiation of drug use to the initiation of injection drug use has gone down. And this is the first birth cohort where we've seen that. So we're pretty sure that exposures that involve injection use are higher risk. We're not certain because we don't monitor this, but we're pretty sure that with fentanyl, if you inject it, you're more likely to get a higher dose, and you're more likely to die from that injection. And we also know, of course, that you're exposed to other hazards when you administer a drug by injection. But we also know that smoking can cause overdose as well, and it would be nice for us to every day take a look at the Vancouver overdose prevention site where they've reported the number of visits that they have, and when an overdose happens, how was the drug administered, and test the drug and tell us what drug was it that resulted in an overdose. If you're anything like me, the most alarming thing about this picture is that there's only 8% of battery left, and that makes me really nervous. I don't know if you see that. So in the clinical realm, many of you would know that the national strategy on prescription drug misuse was called First Do No Harm. And it's a good principle, but I think too often that principle is translated into first do nothing or first do no help, because we don't want to be the guy or the gal who signs the prescription for that drug that causes that person's death. And we often see this in the practice of addiction medicine, unfortunately, where a patient will consistently test positive for opioids. And their methadone prescriber says, I can't in good conscience continue to prescribe you methadone because I'm involved in a risk of overdose. And so you stop. Of course, the risk of that is something happens on the other side in that real life space. And we know from the literature that the number of exposures to illicit opioids goes down in people who are maintained on agonist maintenance therapy, even if they continue to use other opioids, which many do. We don't expect 100% abstinence. We expect about 60% abstinence. And I think that that number will come down in the face of a really, really potent illicit opioid in the market. So the point of this is to say, first do no harm. The spirit of first do no harm is to offer interventions to patients where the risk of offering that intervention is lower than the risk of not offering that intervention, and where you think about that deliberately. And where you're having difficulty thinking about that deliberately, you ask somebody who can help you to think about that deliberately. And you do that with the same construct of hazard modified by exposure and susceptibility gives you risk. And if you walk through that, you hopefully will come up to an answer that does the most right by the patient. Here's just just so you can see what the situation is in Alberta, and I don't think it's that different from BC. So these are age and sex demographics of patients who died from drug overdose related to fentanyl on top, and those where they were related to an opioid other than fentanyl. This is not to say that these are different populations. There's a lot of overlap between the two. But those patients where you see the highest bars in the bottom graph, mostly female in the first 3 months of 2017, and older people who you don't stereotypically think of as people who are shooting up their opioid pills. Things are still happening to patients who we don't either screen for or don't suspect substance use disorder in. And I would say that you should be relatively confident that some of these people are people who don't have substance use disorder. And some of these people are people who are using their medications as prescribed, where possibly a deliberate risk calculation was not done. Unfortunately, the way that Health Canada characterizes opioids is to say, when used properly, they can help, but when misused, they can cause addiction, overdose, and death. They can also cause those things when they're used as prescribed. And that's an important thing to understand, that people can still die when we prescribe things without calculating risk. And if you think about that hazard modified by exposure and susceptibility equals risk framework, in the context of somebody who has a substance use disorder, what are the criteria for substance use disorder? The top two are tolerance and withdrawal. Does tolerance make you more at risk of an overdose? No. Does withdrawal make you more at risk for an overdose? No. Does opioid naive make you more at risk for an overdose? Yes. Does concomitant prescription of other CNS depressants make you at risk of an opioid overdose? Yes. Does alcohol use make you at risk for an opioid overdose? Yes. Somebody who's using drugs on the street is very likely to use a stimulant plus an opioid. That can increase your risk of death, but not the same as the person who's also receiving an antidepressant and an anxiolytic and drinks at night. So you got to think through this deliberately and recognize that even patients who you think are not at risk for an overdose are going to fool you sometimes, and they're going to fool themselves sometimes, and you need to protect them. We need to make sure that we put around them the right supports to retain them in a relationship with us so we can continue to mitigate that risk and all other risks that they face. In the 30 days preceding opioid toxicity deaths in Alberta, a number of things were mined from health services utilization data. And so what we found is in the bottom section there, those are the patients who died from an opioid overdose other than fentanyl. 57% of them got their opioid in the 30 days preceding their death from a pharmacy. That doesn't mean that only 57% of them had a prescribed opioid. It means that 57% of them got it in the previous month. So there must be people missed from that who get their prescriptions every couple of months. There was 46% of them who were prescribed an antidepressant or an anxiolytic. So there's a susceptibility factor in the calculation of risk. It's less pronounced in the patients who die from fentanyl overdose. 16% of them got an opioid from a pharmacy. 19% of them had another CNS depressant or antidepressant. But all of these people, not all, many of these people had contact with the health system. Many of these people were in a position for us to be able to mitigate risk, and we might not have done that. 11% of people who died from a fentanyl overdose visited an emergency department in the 30 days previous. And their emergency department visit was related to substance use, either withdrawal or an intoxication. And only 2% of them were dispensed methadone or buprenorphine from a community pharmacy. So I think that it's fair to say that there were a number of touch points where we could have intervened and helped these patients get access to effective treatment. By the way, anxiolytics, antidepressants, not the only things that interact with opioids, right? In the UK, really, really pronounced impact of the use of what we call opioid-sparing agents, right? Things like gabapentinoids, where the deaths from gabapentinoids appear to follow a logarithmic relationship with the number of prescriptions for gabapentinoids. So that's something to keep in mind when calculating risk in these patients. Okay. So basically the questions we ought to ask, and I think that regulators ought to ask when there's an opioid death: did you identify hazards in the patient context? Did you assess the likelihood of exposure to those hazards? Did you assess patient and environmental characteristics that increase susceptibility? And did you add protective interventions like agonist maintenance, like naloxone, and offer them meaningfully? Not to say you ought to talk to an addiction counselor, but did you actually hold the patient's hand and walk them along to risk mitigation strategies? Did you risk assess and risk manage and harm reduce? And did you do so in a meaningful way? Great guideline from your BCCSU, looking at the things not to do, like detox in patients with opioid use disorder, and offering agonist maintenance therapy. Maintenance therapy prioritized over controlled tapers. If there is detoxification because your patient with capacity makes the decision that that's what fits best with their life, better outpatient for opioid use disorder than inpatient, because it allows you to offer a longer-term withdrawal management and allows them to continue to engage in things that keep them productive. Options in terms of patients who do not respond well to conventional agonist maintenance therapy, things like sustained release oral morphine in structured contexts, when you've consulted with your learned colleagues about how to best manage the risks of that, and of course harm reduction across the board. The only disappointment I have, my Alberta beef with the BCCSU guideline, is that it didn't include supervised injectable opioids, which I think are increasingly, in the context of a high-risk hazard environment, really important for us to entertain. This is the European study, or the England study, called RIOT, which I think was named for what happens when you discuss this amongst paternalistic medical practitioners and the recovery movement. So basically, here's what they found. As good as oral methadone maintenance, but in terms of reduced money spent on illicit sources of drugs, better outcomes in your patients on supervised injectables versus patients on oral morphine. Now, this isn't a specific sample. I would suggest that in a context like this, just as we apply vaccinations in populations where they're not perfectly tested in an outbreak scenario, we also ought not to conflate inclusion criteria with indications. So there may be situations where offering these treatments to certain individuals when they have not, quote unquote, failed methadone or buprenorphine might be reasonable, particularly when the risks of not doing so are significant. Pregnant women, sex trade workers, incarcerated individuals. All right. Jail's really, really important. I won't talk too much more about that. But here's where I think probably the most important things that I will say are. The policy environment is increasing the risk of this drug crisis. You must have read things in the press about how most experts are advocating for decriminalization of drug use, personal drug use. Experts in Canada, but also economics experts from the London School of Economics, including 5 Nobel Prize winners who analyzed all of the data respecting the money spent on investigation and enforcement and prosecution and incarceration for drug offenses have not been productive, have not decreased the number of people using drugs, have not decreased the mortalities associated with drug use, and have likely made those things worse. If it's not a good enough reason to end the war on drugs, then Richard Nixon started it. This, I think, is important. So his White House Domestic Affairs advisor, while he was serving time for Watergate, said to Harper's Magazine, and it was reported in April of 2016, unfortunately after Ehrlichman died, so it can't be verified that he said this. And also keep in mind that he was probably pissed off that he went to jail, and so might have said some things about Nixon that weren't particularly true. But here's what he said. Nixon had two enemies, the anti-war left and black people. We knew we couldn't make it illegal to be either against the Vietnam War or black, but by getting people to associate the hippies with marijuana and blacks with heroin and then criminalizing both heavily, we could disrupt those communities. Did we know we were lying about the drugs? Of course we did. Whether or not it is true that that was a thought process behind the war on drugs, it is true that this has been the impact of the war on drugs, that power has been concentrated amongst the dominant few, and that it has had the war on drugs has had a disproportionate impact on people in vulnerable populations. So in the United States, while there's about 10% of the population is black, about a third of the incarcerated population is black. And if you take that in terms of rates per 100,000 people, almost 3,000 per 100,000 black people is in jail amongst males. And that has a lot to do with disproportionate sentencing laws when it comes to crack cocaine versus cocaine. We should have learned from this. Criminal drug laws result in a change in market forces in the illicit drugs so that poor people use more dangerous drugs. Now, crack is not that much more dangerous than cocaine, but it's cheaper because you have to use less of it to get the same euphoria. And because of that, they increased the sentencing laws such that at the beginning, you would get 100 times the jail time for the same amount of crack cocaine compared to soft cocaine or cocaine salts. This is not just an American phenomenon. In Canada, from right here in British Columbia, great review of what happens with Indigenous people and the legal system, where when you control for all of the things that result in incarceration, you still see a substantial increase in incarceration amongst Indigenous people. You're more likely to go to jail for a drug-related offense if you're First Nation, Métis, versus if you're not. And that has a lot to do with drug law, and a lot to do with why we see a disproportionate amount of death in Indigenous people in this particular drug crisis. Unfortunately, our federal health minister has said that the issue of decriminalizing drugs is not something we're looking at, and her priorities are first and foremost to reduce barriers to treatment. But one of the greatest barriers to treatment is stigmatization and criminalization of drug use. So if you have to go to how hard is it for your patients to come to you and say that they eat a donut for breakfast every day? But eating a donut is not illegal. Imagine how hard it is for them to tell you, really, doc, the thing I'm struggling most with right now is that I'm shooting heroin into my arm, and I'm not sure what exactly it is. How hard for them to say that when they know that that is something that defines them as a criminal. How hard is it for somebody to go to get agonist maintenance therapy when anybody walking through that door is known to be breaking the law? Really, really a difficult thing to expect people would not see substantial barriers to entering treatment if we continue to criminalize their drug use. But at the same time, health minister says that we need to avoid judging those people who are addicted to opioids. Literally, we ask judges to judge them for using their drugs, and we say that the rest of Canada should not. So while there is a press to destigmatize and saying the only way we get out of this is to destigmatize, let's go in that direction, we go in that direction, but we can't go in that direction. It makes it very, very difficult, and despite all of the efforts of declaring a public health emergency in British Columbia, adding access to supervised injection sites and overdose prevention sites, improving access to treatment, we will continue to tread water until we deal with this broader policy issue. And the last few months have taught us that physicians know how to advocate. We know how to speak up. Go on Twitter and search for the hashtag tax fairness. You'll see how many physicians are willing to speak up about issues that affect us. We have to speak up about issues that affect our patients as well, and this is one of them. If you're interested in dealing with the opioid crisis, we cannot do that. We cannot do that without addressing the criminalization of drug use. There's Portugal there. And if you take a look at which European countries have the most progressive drug laws, they're all at the bottom of this in terms of drug toxicity death. There's France, Czech Republic, and in the Czech Republic, judges are given the latitude determining whether somebody is using drugs for personal use versus trafficking with a law that says, if the amount is larger than small, consider it to be trafficking. Larger than small is kind of a good law, I think. So France, Czech Republic, Netherlands, Norway, all in the bottom part of that. Estonia has really archaic drug law, but still 126.8 per million people dying from all drug toxicity death, versus in British Columbia, where we're looking at 200 in 2016, which was almost half what we'll see in 2017. So the last thing I'll say, I referred to us being gathered on the traditional lands of indigenous people in the Pacific Northwest. And where I come from, it's Blackfoot country. And so a Blackfoot elder once explained to me what community means to her by describing how Blackfoot women come together to build a teepee. And so there's 4 women, each with a specific task of bringing one pine pole to where the teepee will be built, and they put them together. And then one other will tie with a single animal hide the top of those 4 poles. And then others will bring more sticks to form the structure of the teepee. And then 2 will bring a large animal hide to wrap it. And then 1, with great wisdom, will paint on it a tribute to the earth. And she explained that similarly in a community, everybody has a job. And similarly to a community, the structure of the teepee is supportive of, each part of the structure is supportive of all the rest of it. And even if one stick was to bow or to splinter, the others will hold it up. But if you take the defective one away, the entire teepee will fall, good sticks and bad. And so what she explained to me was that the measure of a supportive population is not how you take care of the weak member, but how much you depend on each other. And I think that, whether it's organizations, individuals, or us as colleagues, the way that we get out of this is by supporting each other and by supporting the people who are our patients, and to do so outside of our examination rooms. And God help me if bureaucrats could look out the window and out of the windows of their ivory towers and recognize that real life is going on around us and we have to deal with it in a practical way. If we could do that, we might get somewhere. The American Medical Association in 2001, after September 11th, reviewed their code of ethics and added into their credo that humanity is our patient. It's not just about what happens in the examination room. We have a responsibility to things that happen around us, and we need to use our voices for that. So I hope that on a Friday afternoon I can compel you to spend the weekend doing some of that. So thank you.